So now moving on to the next session. Ladies and gentlemen, hold on your chairs because the guns are going to shoot out as we are going to have a debate on demyelinating disorders. And so we'll be having a hot discussion on whether the definitive therapy is superior to infinite therapy in management of MS or not. So I would like to invite our panelists for this session, Dr. J.D. Mukerjee from the Max Super Specialty Saket, Delhi, Dr. Anshu Rohatgi, Senior Consultant Neurologist, Professor at Gangaram Hospital, Delhi, Dr. Dheeraj Khurana, who has special interest in stroke and multiple sclerosis. So please, sir, please come onto the stage. And I would request the chairpersons to introduce our speakers, Dr. Thomas Mathew and Dr. Rohit Bhatia. Please, sir, please come on the stage.
Thank you. Good morning, everybody. I, along with my co-panelist, welcome two stalwarts in neurology in India and abroad, Dr. Thomas Matthews and Dr. Rohit Bhatia, who need, in my opinion, no introduction to this august audience. And they are an icon on themselves. And they're going to talk on very important topic. Dr. Thomas Matthews has opened the discussion on finite therapy superior to infinite therapy in management of multiple sclerosis. Just to set the context, we have varied phenotypes of multiple sclerosis. We all deal with it and it's difficult. But essentially the treatment is two. One is immunomodulation, immunotherapy versus treatment of the symptoms. Without wasting much time, I'll request Dr. Thomas Matthews to deliver his talk. Thank you.
Thank you. Thank you, chairpersons. And special thanks to Dr. Arun Garg for inviting to this fantastic session and also to this fantastic place with all academic feast and otherwise. Thank you, sir, once again. So without wasting time, we'll go to the debate. And first I will speak for finite therapy, and then Dr. Rohit will speak for infinite therapy. So finite therapy versus infinite therapy. If in any disease, if something can be limited and definite, then nobody will go for anything infinite. So finite therapy, there's no need to debate because finite therapy is almost always we prefer if there is a finite therapy. There is no question of debate when there is a finite therapy. But the problem, we'll come to that, what are the little problems with the finite therapy. So finite therapy is also called highly effective treatment strategy. You go with a highly effective treatment. So it is for a limited period of time. There is more chance of control and cure. And there may be, financially, they may look a little upfront costly. But if you do the health economics, in the long term, you might have financial benefits. And the heat is also called the immune reconstitution or immune reset. And because they're highly potent, very effective, and you have side effects, but over time, we learn how to manage, mitigate these side effects so we can use it in the upfront. While infinite therapy is long-term, and in diseases like MS, it's lifetime, and you on the way, you know that any drug has a side effect, and many times over the time you use, like natalizumab, you get risk of PML and things like that. And compliance becomes an issue when you have long-term treatments, especially oral medications, patient may not be taking the medicines, and then the cost also builds up over time. So for finite therapy, we have what are the agents we have. One is alemtuzumab, then you have cladribine, and then you have the autologous hematopoietic stem cell transplantation. Dr. Ravi, in his presentation, told that we are just moving forwards in the way going more towards the finite therapy to various reasons. And these are the reasons. Highly effective treatment strategies are important because brain damage in MS occurs early in the course of the disease. Axonal injury occurs maximum early in the disease when inflammation is active. And it's a slide showing the amount of axonal damage. You can see in the first year of illness, you have the maximum axonal damage. And over years, more than 10 years, the axonal damage is less. So the axonal injury occurs along with inflammation in the beginning of the MS. And you loses the valuable time. The time is brain in MS also like stroke early in the course of the disease while you are using less effective agents which are not enough to control the inflammation. And so the maximum use of this early window of opportunity is important when the inflammation is maximum, and to administer the most effective drugs, which we use in all other diseases of immunological disorders and cancers. We go upfront and you don't wait it to smolder and smolder. And it is worthwhile to remember that even a highly aggressive strategy like bone marrow transplantation may not work in a patient with established disability. It's very difficult to improve when something is established. And your discussion, it came up when the white spots are appearing in the MS, it doesn't go off. So that means you don't wait for years and years and keep on doing the MRIs and seeing what next lesion. Counting lesions doesn't look a good strategy for a long-term disease. So this is an article which came in Lancet Neurology in 2020, where they found that high efficacy therapy commenced within 2 years of disease onset is associated with less disability after 6 to 10 years than when commenced later in the course of the disease. And it's another article which showed that an initial disease-modifying therapy is important with regards to late conversion to SPMS. Patients with RRMS who had initial treatment with fingolimod, alemtuzumab, or natalizumab was associated with a lower risk of conversion to SPMS versus initial treatment with glatiramer acetate or interferon, showing that beginning is very important and how well you begin is much important which are the late sequences like progression and conversion to SPMS. So let us see the agents in finite therapy. We will see their advantages and their disadvantages, and we will be spending a little more time with autologous hematopoietic stem cell transplantation because I think that is where we are heading. So alemtuzumab is an anti-CD52. The CD52 is expressed on all lymphocytes, monocytes, natural killer cells, and dendritic cells. When to infuse alemtuzumab, there is a rapid depletion of all lymphocytes, especially T helper 1 and T helper 17, which are important in multiple sclerosis. Treatment is 12 milligram per day for 5 consecutive days, and after 1 year, 12 milligram per day for 3 consecutive days. The advantages of alemtuzumab are its finite nature and short dosage regimens and high efficacy. Around 50 to 60% need only 1 course of alemtuzumab. But there are a subgroup of patients you may need the 2nd, 3rd, and the 4th infusions, but they are pretty less. The main disadvantage with alemtuzumab is the various adverse events associated with it. The infusion reactions occurs in around 92%, but we know how to manage the infusion reactions. Anaphylaxis occurs in about 3%. FDA has issued a black box warning on the risk of acute stroke during alemtuzumab infusion. Graves' disease can occur in 34%, but most of these diseases are manageable. ITP occurs in around 2% and Goodpasture syndrome in around 0.3%. There is a 0.3% risk of malignancies of thyroid, melanoma, and tuberculosis due to decreased immune surveillance. So alemtuzumab, you see, it's good, and it is almost like a chemical bone marrow transplantation, as Dr. Ravi rightly mentioned. And coming to cladribine. Cladribine is a deoxyadenosine analog prodrug, preferentially depletes lymphocytes, is the first finite oral disease-modifying drug. Again, 2 short courses, 1 year apart, and it is for adults with highly active relapsing MS. In week 1 and 5, that's the first course, you give a cumulative dose of 1.75 milligram per kg. For a 50 kg man, it will come to around 90 milligram. So 10 milligram tablets you give for 5 days daily in the first week. And the next month, the first week, that is the 5th week, you give another 4 tablets. So that is a course 1. And repeat the same course after 1 year at week 48 and week 52. And that's how the cladribine is given. And if you see the potency or the power of the cladribine with respect to the annualized relapse rate, cladribine works around almost better than interferon, glatiramer, and DMF, which is around 30% to 35%. While cladribine is roughly equal to fingolimod, so around 50 to 60% with respect to annualized relapse rate, but it is inferior to natalizumab and alemtuzumab with respect to its power. So if you position the various treatments, you can see the B-cell strategies come top and just comes below Tysabri, and alemtuzumab is almost up there. But the problem with alemtuzumab, as you know, the cost and the side effect. Now come to the autologous hematopoietic stem cell transplantation, the new kid on the block. So it's a highly effective strategy for aggressive MS. You do an immune reset, and the data and experience with autologous hematopoietic stem cell transplantation is evolving. The concept of immunoablative therapy and rescuing with autologous hematopoietic stem cells is not new. It is usually used in refractory autoimmune diseases. This is the HALT MS trial by Atkins et al. From Canada. There are all small numbers of patients, but you just know the trend of what is happening. Here, a medium intensity conditioning protocol was used with busulfan, cyclophosphamide, and antithymocyte globulin. Around 86.6% of patients were relapse-free at 3 years. Progression-free survival was 90.9% at 3 years. 35% of patients had sustained improvement in their EDSS score. They found that the rate of brain atrophy decreased to that of expected for healthy controls, that rarely you can achieve with any medications. And one of the 24 patients died of transplant-related complication. So the next trial by Burt et al. In 2015, around 100 plus patients, around 150 patients, the 4-year relapse-free survival was 80%, 4-year progression-free survival was 87%, significant improvement in EDSS pre-transplant median of 4 became at 2 years 3, and at 4 years 2.5, and there was no treatment-related deaths. So we are just evolving with how to use the bone marrow transplant, what drugs to choose. You go for a high effective treatment or a modest effective myeloablation, so you are just working on that. And around 4 out of 151, 2.6%, had a reactivation of the herpes zoster, so that's not a big thing. We can treat with acyclovir. But problem with the Butts regimen in 2015, for immunoablation, they had used alemtuzumab and antithymocyte globulin, and there was an increased risk of ITP and thyroid disorders, and especially in the alemtuzumab group when compared to the ATG group. And no post-transplant cancers in cyclophosphamide and antithymocyte globulin group, but 2 patients treated with cyclophosphamide and alemtuzumab developed cancer, 1 breast and 1 lymphoma. So the EDSS improvement in this study was noted to happen only in patients with duration of disease less than 10 years, and those with RRMS, and those with SPMS and disease more than 10 years, they didn't improve with the EDSS score. While the baseline EDSS score, older age, and prior number of immune modulation or suppression regimens was not associated with worse outcome. That's the good news. And there's a trial called MISS trial, which is a RCT. They compared non-myeloablative hematopoietic stem cell transplant with continued DMT treatment, and various parameters were seen, and the disease progression occurred only in 3 out of 55 hematopoietic stem cell transplant group, while 34 out of 55 in the DMT group had progression. And during the first year, the mean EDSS score decreased in the HCST group from 3.38 to 2.36, while it worsened to 3.98 from 3.31 in the DMT group. And this is the pictorial representation of time to disease progression and time to first relapse. There were no deaths and no non-hematopoietic grade for toxicities. There's another trial where compared autologous hematopoietic stem cell transplant to alemtuzumab, and they found that the patients achieved NIDA more in the AST group compared to alemtuzumab treated patients. 37% of transplant showed an improvement in EDSS compared to none in the alemtuzumab group, and the cognitive function was significantly better in the hematopoietic stem cell transplant group. And at present, in 2019, there were 8 retrospective studies, 8 clinical trials, 3 meta-analysis and systematic reviews showing that bone marrow transplant is efficacious and safe and improves clinical relapse, MRI activity, disability worsening, and reverses disability without unexpected treatment. And the latest article in 21 from Mexico is really mind-boggling. They have used the hematopoietic stem cell transplant 1,000 plus patients, around 1,200 patients, and you can see that in Mexico, the transplant rates are going up from 2006 they started, and it has gone up in 2004 due to various reasons. And their regimen is interesting. They're just using cyclophosphamide and rituximab for immunoablation. There is no alemtuzumab, no ATG, and then this is an interesting regimen. And if you see the entire study starting from, you can see the effect of interferons in the progression-free survival. Various drugs, they're all below 50%, and while you can see the bone marrow, the progression-free survival is onto the other side, and you can see all of the major studies, and the 2019 also from Mexico, and 21 from Mexico. So in the Mexican method, they use non-frozen peripheral blood stem cells. They refrigerate the blood cells 4 days, not the frozen one, and they did outpatient basis the bone marrow. That is fantastic. And a non-myeloablative regimen, and 1,000 patients, the transplant-related mortality is 0.2%. So that is amazing. And morbidity was less than and no major morbidity because they changed the condition regimen. So this is the Indian studies. I think Dr. Kameshwar Prasad had one patient, 33-year-old, did a bone marrow, and then we have one from Haryana by Dayama et al., where they used autologous hematopoietic in 20 patients, and they found it to be beneficial. So I'll conclude in 3 slides. No other therapy for relapsing remitting MS has demonstrated significant and sustained improvement in disability and quality of life and sustained lack of new disease activity. And the American Society of Blood and Bone Marrow Transplantation has told it is MS is a standard of care, clinical evidence available, indication for autologous hematopoietic stem cell transplant. So collaboration of neurologists with expertise transplants in treating MS, and transplant physicians with experience performing autologous hematopoiesis is the future. I talked to my hematologist. He told autologous hematopoietic stem cell transplant is just like treating paracetamol and fever for us. There is nothing, especially for diseases like MS, mortality is 0%. And he gave the statistics. Anyway, so finite therapy appears autologous stem transplant first, followed by alendizumab and cladribine. And finite therapy is absolutely superior than infinite therapy. The best agent for strategy and the best regimen is evolving, and the best at this moment appears autologous hematopoietic stem cell transplantation. Thank you.
Thank you, Thomas. We should have done a poll before the debate started, but it's still not too late. So we would just want a show of hands here. I'm sure people have not as yet made their opinion, which is better. So can we have a show of hands who in this audience believe that finite therapy is better than infinite therapy? Finite meaning thereby, okay, great.
I think very few hands, Thomas. Yeah.
So we'll see.
We'll see.
So while
So I
Rohit,
think-
I believe, has fueled himself, we gave him time, so he can start with his seething attack on finite therapy.
So I'll just introduce Dr. Rohit, and I think Dr. Rohit needs no introduction. Everybody knows him very well. As said, he's an iconic figure in both in stroke and MS in India right now. So can we have his introduction slide, please? Okay, chalo ji.
Can you hear me? Where is Thomas? You're right on the firing line. Okay, so we are whatever it is, but we are friends. So if you're going to be at the cliffhanger, I'll hold you still. So debate among friends is always difficult because what is in the hall is not outside the hall. And it's always a decision that we all take together as friends and colleagues. Okay, so as rightly pointed out by Thomas, what we aim for in MS is always a cure. And we aim for no relapse, no imaging deterioration, no worsening of disability, and we want independence. No treatment till date has achieved that in RRMS. Talk about SPMS and PPMS, it's a different story. But none of the treatments till date can be 100% cure for 100% patients. So that's the first reality check that we need to have. In the usual pyramid that we follow in any treatment, we follow with the platform agent, second line, and AHS-CT, the third line, but we always modify this algorithm depending on what the patient actually needs at the time we evaluate the patient. It's not that I can fit a shoe size of 12 if my shoe size is 7. So that's something that we have to be certain about. And in any MS treatment, and this slide is very repetitive with most of us, is we always look for treatments which are effective, but also have low burden of treatment, cost, and management. Don't forget, the big liner is safety. So in pragmatic treatments, we need to bridge safety and efficacy as well. So what are the true definitive so-called finite treatments? And Thomas, you tweaked your debate a bit by bringing in the heat therapy. Well, the true finite treatments are the ones which we don't need to repeat. We do them once and we are done with it. And I'll show you that even in all these three, there is nothing like an absolute finite, but it's close to finite because we have time points of treatment. But what we talk about is we must differentiate them from highly effective treatments. For someone who's getting rituximab once in 9 months or 12 months, it's kind of a pseudo-finite for that patient. Now, come on, Thomas, you are the rituximab man. So that's what it is. So in two strategies that we commonly follow in practice, we go for escalation or we go for induction. And there are clearly two sets of patients when we talk to them about in the clinic. The ones who believe in an aggressive role, and they say, doctor, don't give me all this crap that you're talking about every day, every 2 weeks. You give me something that will really work for me. And there are people who say we will go for natalizumab right away. We want to go with rituximab right away. And there are people who say, no, doctor, I'm concerned. I would like to go slow and steady, and I'll see how I do. So that's what is the typical, most of us, escalation strategy paradigm that we all tend to follow. And why I want to show this slide to all of you is because there are these chronic maintenance therapies on the left, among which there are some of them are very effective, and they are used for malignant MS as well. Whereas what we are talking about here are actually the pulse therapies, which have some finite pattern. And that's why most of them are HSCT, alemtuzumab, and so forth. But let me take you a bit to the evidence. And in the evidence, if you look at it, this is the grade of recommendation, which is about the quality of a study and how it is graded. And on the top you have, do we have a pointer for this? On the top we have relapses over 24 months, and then we have disability worsening over 24 months here. So the grade of the evidence is moderate, in fact, for alemtuzumab, but it is high for natalizumab. Similarly, in a disability worsening, it is moderate for natalizumab, but it is actually low for alemtuzumab. But of course, if you build it, the probability is that you will have a higher control with alemtuzumab, more than a bit with natalizumab, and same is true for disability worsening. So we know that there are relatively slightly more effective drugs. But let me also take you to something called no evidence of disease activity, and that's what's a true finite part of a treatment. You took an antibiotic for a boil and the boil got okay and you forgot the doctor for the next 30 years. Now that's not the true story. This is how it drops progressively. For alemtuzumab, in the 2 years it dropped and people required multiple more infusions in at least 20 to 30% people. Same is true for even the cladribine, but what was most sustained, as Thomas rightly said, was from the HALT MS trial of bone marrow transplant, where it had more sustained efficacy. Look at the next slide, which I will show you, is again the no evidence of disease activity. But if you look at this diagram here, in fact, natalizumab has a much higher no evidence of disease activity compared to alemtuzumab from people who are having no evidence of disease activity at 2 years. So the jury is still not out. Which is better does not mean which is more louder. We need to also show evidence. And this is the changing landscape from a country like Sweden. They have a lot of people like you, Thomas. They love rituximab. See how it has grown. All of this has fallen progressively, and rituximab has progressively grown to be one of the most frequently used drugs because of its efficacy, safety, and tolerability. And of course, natalizumab and others follow the rule of the thumb. Now, if I show you this diagram, and this is not for teaching, of course, we have most of the MOMABs that we talk about all the time, and the recent one is ofatumumab, and just published trial of obinutuzumab for MS as well. All of them show that they are probably effective agents, right? Now let's look at the CARE MS1 and CARE MS2 trials. What is the point of comparing a superior drug to if Dheeraj is going to fight with me, he's going to win. I'm thin and lean, and he's a strong, astute man. So you're comparing, of course, head to head with interferon, and you obviously will show better efficacy. Same true is for cladribine. Cladribine was compared against placebo. It's unethical to do trials with placebo in MS, but FDA wants that. Okay, so look at this, 31.5% extra alemtuzumab cycles and 42% additional alemtuzumab cycles were given to patients. They were dissipated, of course, 1, 2, or maybe less than 2 or more than 2. And the NEDA, which was NEDA 3 after 5 years, was 27% only. So there are patients who look like finitely treated, but long-term are not finite truly. They will deteriorate with time. And there is a lot of issues with alemtuzumab use, and it's not easy to make a decision. Pragmatically and practically, we have to be concerned about its significant adverse effects. And the list kept on growing, and we had a black box warning of stroke now also with alemtuzumab. This is one of the studies which actually compared retrospective data which is based on a propensity score matching. So you have similar people. So look at this. For alemtuzumab, the annual relapse rates were similar with natalizumab. Natalizumab is a highly effective drug. It is not finite, but it works the same way with less side effects. The risk in JCV seronegative patients is probably not even known for PML. Probably it's 1 in 10,000 and maybe 1 in 1 lakh. In JCV positive, we are not stupid to continue using natalizumab. So we will change the drug, right? And of course, similar disability improvement risks. I won't bore you with this. The FDA says, because of the safety profile, the use of Lemprera should generally be reserved for patients who have had an inadequate response to 2 or more drugs treated for MS. You can't just give a patient alemtuzumab right away in every patient. There are selective patients that you want to use that drug, okay? So, long list of concerns, and my main concern is only about its safety. That's one of my main concerns. Same true for cladribine. The problem with cladribine is again the same. You compare against placebo and show it works. But in many countries, it is not used. And oral cladribine is not available in India. It's only injectable. So where will you get it, ladies and gentlemen? Run around and find cladribine for patients? It's not possible, right? And about the bone marrow transplant, it's a great achievement. I'm fully with you, Thomas. But someone who says I have 0% mortality is like a surgeon saying I've never gone wrong in the OR. That's never going to be there. Even with the best of the data, it is 2.1% pooled estimate. So if you tell a person that we're going to treat you, but there is a 2% risk you may die upfront, and this is a finite therapy, 99 out of 100 patients will refuse to go for AHS-CT as a first-line management. It's not going to be an easy decision. Most of your patients have failed primary line therapy before you have asked them to go for AHS-CT. So that's what we remember. Just last 2 slides. What about progressive MS? Where is the evidence of finite therapy in progressive MS? We don't have it as yet. Only the pulse therapies have some evidence. So they are not going to be forgotten, right? And same is it true here. So this is just last 1 minute with your permission. This is a JAMA Neurology paper in 2021, which compares from 2 different cohorts, Danish and Swedish cohorts, of people who are treated with escalation or what you said, Thomas, highly effective therapy, not finite therapy. If you look at the breakup, I think this is a bit blurred, the screen, I don't know why. There is no patient in both the registries who is on alemtuzumab. Most of the people are on rituximab, natalizumab, and fingolimod compared against the less effective therapies. And what it clearly shows was that the Swedish pattern of treatment clearly showed better achievement of ARR reduction and better achievement of disability reduction. So pragmatically, where are we? Where are we with all these 2 kind of drugs? We have some positives and some negatives for both the agents. And one important thing about long-term tolerability is that we have more certainty about these pulse therapies and effective therapies, but we have no certainty about these finite therapies for long-term tolerability and efficacy. That's a problem. So the question in the last 2 slides is it generalizable to all populations? That you have any patient you see of MS, you tell him, okay, we have a finite therapy, let's put you on alemtuzumab. No, listen. I also have bone marrow transplant for you. Would you like to get it done for you? Then we say, no, wait. I have cladribine also. So think about it. So it is not generalizable. Look at the cost. In this country, you are successful today by treating MS because you have generic drugs also. Otherwise, this was the most unsuccessful point of treatment for most of us sitting here. It was not easy for us to treat our patients. Number 3, practicality, availability, risks. And what about evidence of superiority against already existing drugs? We have no evidence for that. And of course, the highly effective therapies which are available may be of same efficacy. So my last point is, the last slide. Thomas, Mathew. My last point is, treatment for MS is always personalized medicine. If you see a bad patient who is relapsing in the last 1 year 6 times, me and you are not stupid not to offer him a highly effective or even a, what we say, finite therapy. But if a patient who is EDSS of 0 with just 1 relapse comes to you, I'm sure you're going to put him on a pseudo-finite therapy. Sir Thomas, desk is yours. Come on back. Thank you very much.
I would request Dr. Thomas for a rebuttal.
I'll stand here only and rebut.
Yeah.
So I think agree we both, yes. So
Nee, we want you to tear each other's shirts.
yeah. So Rohit has told the other way what's happening, what we are doing now. I was just looking a little futuristic, and the cost of the bone marrow, that was one of the blogs Rohit has put up. The cost is based on what regimen you use. If you're using anti-thymocyte globulin, it's very costly. But the day if you're using cyclophosphamide and rituximab like the Mexican way, the cost is just 1 lakh. That's it. I discussed the hematology. So they're telling the cost of a bone marrow is what anti-thymocyte globulin, that is the cost. And what you put, and if the outpatient thing they have done, and that their regimen is cyclophosphamide, just for 2 doses, and total dose is 200 milligram per kg, and then just 1000 milligram of rituximab. That is a conditioned regimen. The advantage looks like that, as we believe, like Devi was telling. We have a practice of giving natalizumab in the beginning of the disease to get an immediate control, and then after 6 months or 1 year, give a gap and then give rituximab to follow it up. So same way, if you think, you do a bone marrow with a rituximab cyclophosphamide conditioning, you get a good beginning, reset the immune system, and by chance, as Rohit was rightly pointed out, over years, the effectivity may come down, then you can give rituximab and follow them up. So it gives a good insight into the way it comes, and I think the discussion has made it very, very clear on all the treatment aspects. And as he rightly pointed out, now we have to choose the patient we have to tell everything to the patient and let him choose which direction he wants to go. Thank you, Rohit.
Okay. Rohit.
I'm not contesting that AHSCT has a high evidence of efficacy. The question is the generalizability of a treatment and the choice of a treatment. So the choice of a treatment, I'm again reiterating, in MS is designed to suit the patient's story of the disease. You may say that 10 years down the line, we say that, okay, this all long-term treatments are not really cost effective. Bone marrow transplant is the most cost. So we are not discussing cost effectiveness. We're talking about superiority. Yes, it is likely superior. There is no question about it. But the question is also generalizability of the superiority. So what I want to just end with is that we do agree to disagree in some points, but I still reiterate the fact that you have other treatments also which are pseudo-finite and they work possibly effectively. The choice that every clinician sitting here needs to make, and that's the last liner of my end of my debate, is choose the right drug for your patient at the right time. If your patient needs a finite therapy at an X point, give it. Don't delay that. The problem in MS is the delay and the right choice of the treatment, not between finite and infinite. Thank you very much.
Okay, thank you, Rohit. So before we go on to take a poll again, although the audience was already sold out to the infinite aspect, I would just like to make a comment. Both the speakers did an excellent job, and in their respective motions, they gave a great presentation. However, I just have a comment to make. You know, in conditions like this, to decide whether one therapy is better than the other, not only as is the current trend, but that makes a lot of sense into knowing how is a patient feeling, and both the speakers forgot about it. How do the patients feel about the treatment, the quality of life between one treatment versus the other? And I know because that would be one point would factor in the decision making whether this versus that is better. So could I have a comment from any of the speakers about the quality of life?
When I said about personalized medicine, when I talked about initial discussion with the patients as my...
Yeah, so do we have any data on finite versus the infinite therapy?
Birth study, there was a lot of parameters they have checked. I didn't put it up because for the lack of time, and so they have done quality of life in MS and the MSFC numerical rating score, and all were significantly better in the bone marrow transplant group, from fatigue to cognitive function to the quality of life. So it is because we have no experience with bone marrow, we have not done for bone marrow, so that initial barrier is there with us. But once you start, I think that's what the graph of Mexico is also showing. They started with 1 patient, 2 patients, you get a grip on the process, you get confidence. Same thing with rituximab. In 2013-14, we told rituximab, everybody frowned, and except Dr. Agarwal came and hugged me, but all others were frowning. But now the rituximab has gone up. So it is just how you use and how you get the feel that what drug is doing. I think we should start doing that.
Although, yeah, I agree that quality of life is important, but we don't discount the fact about evidence and the cost.
Yeah, I definitely
so we need to
agree.
create a balance.
Yeah, I definitely agree with Rohit that you don't have head-to-head RCT,
Yes.
maybe with the rituximab or a
That will never happen.
That may happen also.
No,
we can see.
it's an ongoing RCT.
Yeah.
We are waiting for the results of this international trial where they're comparing AHSCT against established HETs.
We have one that I had presented.
There's
that
one-
Vertitel
I think
compared
there's-
already DMT with
there's
small
one-
55
There is one
patients.
going on. I
Yeah.
think it will finish in 2028.
Yeah.
So Dheeraj, the point is that in any treatment of a chronic disease, when you have multiple drugs available, it has to be a shared decision making.
Obviously,
We
yes.
just can't tell a patient, this is what I think is good for you and you please do it. I have 2 patients in my ward right now relapsing MS, failed rituximab and natalizumab. I have asked them to do HSCT. Both of them have refused Thomas Mathew. They say, doctor, I cannot take a risk of even dying 0.01% because I have a family. You give me any other medication, I'm ready to accept it. So you may say that AHSCT, the Mexico regimen, pata nahi wahan pe kaun log jaake karate hain. So the question is, it's not about showing the numbers that we've done 1,000. The question is that if you talk to a hematologist, you talk to someone, everyone will say we can lessen the intensivity of the regimen and lower down the mortality. That is still not 0%. Even in the last meta-analysis, cannot be 0%. So the bigger question here is that efficacy is at one point, safety is at the other, and there's a bridge that we always have to make. There is no question that we will offer this to our patients when it is needed. The question is, do we need to offer it upfront to every patient? There are patients of first attack of MS, CIS, who have even undergone a bone marrow transplantation because it has been told to them that this is the best treatment.
Okay, I think thanks. We're running short of time, so let's have the last show of hands. Who still believe? I think yes, sir had a comment to make, Dr. C. Chandra.
I just want to make a comment. It was a very good debate, which we discussed about finite and infinite therapy. Who doesn't want finite therapy? Everybody wants finite therapy. In any disease for that matter, whether it is epilepsy or whether it is multiple sclerosis. But multiple sclerosis with its disability and what is going on in a long term, everybody wants finite therapy. But do we have the data of long-term follow-up? The long-term follow-up is still waiting. Thomas Mathew argued very beautifully, finite therapy is very important. But we require long-term follow-up. Then only we will be able to say that. So we require long-term follow-up. We require quality of life for the patient. But as Dr. Bhatia has mentioned, this cannot be used upfront. Definitely not. Nobody will use a finite therapy at the upfront. But there is a scope for the use of finite therapy in selected group of patients. And that is why more and more we debate about these disorders, more and more we talk about personalized medicine. And hence, we require personalized medicine as the main goal of treatment in most of the diseases, and it doesn't prevent even in multiple sclerosis.
Agreed, sir. Thank you. Thank you so much.
Thank
So
you,
the last
everybody.
show of hands for and who would all go along with finite therapy currently? Oh well, I think the hands are still low, but there is a good number. And as sir mentioned, when we have more data coming in, long-term data, huh?
I'm going to ask.
Oh,
Yeah,
okay,
yeah.
fine.
I think
That's a
how
good
in
idea.
favor- how much in favor
There could
of
be
going-
indecisive people. How many would go with infinite therapy?
Oh,
Well, still
Oh,
there's a portion of the hall which is, I think, indecisive. So, but still, the infinite therapy scores over the finite therapy still. So, and I would really be happy if everybody could take one side. But anyways, like sir mentioned, we need more evidence, and of course, long term, not only efficacy but also safety. Safety is extremely important in all these MS therapies. Until then, short of the debate, of course, we need a personalized approach and a shared decision making. So, thank you, everyone.
Thank you.
Thank you, everybody. That was indeed a great debate between Dr. Rohit and Dr. Thomas Matthews. I think both of them did great justice to their topics. And I think the course is infinite. We have to, it's a long way to go. We don't have a finality in any of the treatment, and it's in a process of evolution. I think in due course, we will all reach finite versus infinite. We'll come to know after many years. I think it's just an evolution process. Thank you very much for your participation. God bless. Best wishes.
Thank you so much. Thank you so much for nailing that discussion, Dr. Thomas and Dr. Rohit. Thank you so much for our chairpersons, Dr. J.D. Mukerjee, Dr. Anshu, and Dr. Dheeraj. Thank you for enlightening us with such a great knowledge. Thank you.